I have the pleasure of moderating this session, and I am very excited to introduce my fellow esteemed panelists who are going to be participating. So we have Nicole Richie, who is the Global Head of Health Equity and Population Sciences, Science with Genentech. Nicole is the Global Head, as I said, of Global Health Equity and Population Science. She leads the vision and serves as the product development lead responsible for developing and operationalizing strategies to drive greater inclusion of representative patient populations in clinical research, and also to enrich data supporting the optimal use of Roche medicine. Nicole also is the site head for product development at the site in San Francisco. Joining Nicole is Dr. Darrell Gray, and welcome, Dr. Gray. He is the inaugural Chief Health Equity Officer for Anthem, a role he assumed in August 2021. And in this role, he leads the development and execution of a comprehensive strategy to both accelerate whole person health, that means social, physical, and behavioral, and to advance health equity among Anthem's more than 45 million members and the communities that Anthem serves. So, and a very distinguished career before joining Anthem, and also very active in many of the national and local organizations. So we know that Anthem is very fortunate to have convinced you to join their ranks, both of you. So thank you so much for being willing to participate in our inaugural Health Equity Summit. And I want to start with just asking each of you to kind of comment on the things that, first of all, kind of your approach to setting your health equity strategy and how you have been building the case, if you will, for this work within your organization. So I'll start with you, Nicole. I know you've actually been the Chief Health Equity Officer at Genentech for 5 years, so Genentech was a little ahead of the curve. But give us some input and feedback on how you have been building your strategy and the support for it and moving forward.
Absolutely. Thank you, Marian. It's an honor to be here with you and with Dr. Gray today. So I've actually had the fortune of working in this space for the last 5 years. It was only created as a position about 2.5 years ago. So a lot of it was on top of day job, but it was a real honor to start the work at the organization. And I did so in partnership with Quita Highsmith, who's now our Chief Diversity Officer at Genentech, and we've both continued that work. The way we've really thought about our strategy is threefold. It's a very focused approach as a drug development organization. And as we think about health equity, largely the lens that applies to within a drug development organization is going to be in the research space, right? So a lot of our focus is really to have more representation in clinical research programs and in the evidence we generate for the molecules we're developing. And what we've really done in that is focused on the disease areas that most disproportionately or differentially affect patients of color. And that focus has been a really important component of driving our organizational change, because health equity can seem infinite. And the more focused and finite and specific we can make it, the easier time we've had gaining traction within our large organization, with also the appreciation that we have to tackle those elements, the broader elements as well. The second element of our focus is really on data. So real world data and the data resources that we're using to develop personalized medicine. So we're working, Roche as a global organization, to leverage our footprint in global regions to enrich the data and make it more representative, both at the clinical and the genomic level. And then finally, the third area of focus within our strategy is on partnerships. So I think we all appreciate that shared responsibility and partnerships across the healthcare ecosystem are incredibly important in achieving or focusing on health equity. So we have a very explicit focus on partnerships with healthcare providers, with patient advocates, with community leaders to inform, shape, and validate our approach and how we're thinking as an organization.
Excellent. Thank you. So now, Dr. Gray, when you look at an organization like Anthem that has, first of all, 45 million members, but also the remit, right, that your organization has and what you are doing with leading the development of a strategy that's going to focus on the whole person health, which totally gets so much to health equity and social determinants of health, and how you're looking to do that, again, the social, the physical, the behavioral. How are you putting together, and recognizing you just started in August, so I do understand that, but just to get your thoughts about how you're approaching that and how you're prioritizing and what kind of systems and structures are you putting in place. And again, this is so important because, as I mentioned, so many organizations have created these roles. And thank you, Nicole, for clarifying that it really is within the 3 years, because only 2.5 years you add the health equity piece added into your role. But more and more folks are. And these new health equity leaders now are putting together their strategies and looking for ideas, learnings, partnerships, all of these things. And that's why I think it's so timely for us to be having this conversation now, and for you, Dr. Gray, to talk about how you're approaching it.
So thank you very much. And I share Nicole's congrats and thanks for this, being able to participate in this summit. And Nicole, it's wonderful to join you as well. I'll tell you, even though I joined in August, I've been fortunate to work alongside so many people so that I could hit the ground running. One of the things we think about health equity, particularly defining what it means to our organization, that was key. And ensuring that everyone has a fair and just opportunity to be as healthy as possible is our North Star. And so as I began to work alongside others and thinking about what does that look like as far as strategy and execution for our organization, as you mentioned, our focus is also whole person health. So it's not just focusing on what happens within the walls of clinics and hospitals, but where people spend most of their time, at home, in the community. And so if we are to be effective in advancing health equity, we have to be effective in all of those spaces. And so, as I look at my role as Chief Health Equity Officer, my role is one, to make sure that health equity is everyone's business. It is not just my business to drive this forward for Anthem. It is all of our business. And so as Nicole started to say, it's about organizational change. It's about behavior change. And so part of that is ensuring that, look, everyone understands that health equity is a moral imperative, but it's also a social and business imperative for us as well. There's so many use case examples that I can give, whether it's the member who not only has a chronic health condition, but actually has a more upstream issue facing, housing instability or food insecurity that put them actually at risk, that made them vulnerable for that chronic health condition. That's where we have to go. We have to go further upstream and not settle for treating that chronic health condition alone. And so as I think about it, it's interesting that Nicole said that she has a kind of three-pronged approach, because mine is similarly three-pronged. And I'll distill it just for the purpose of this conversation to three prongs. And I think about what we're doing, particularly around a focus on care delivery and experience. It's most important that we center the lived experience of our members. Why is that important? Well, I look at myself. So it didn't come across in the introduction, but I'm a believer. I'm a husband of almost 11 years. I'm a father of 3, almost 4 kids, 4th due next month. I am a physician, a community advocate, but I say those things because it's that intersectionality that makes me who I am, that has afforded me opportunities that I recognize that some people may not have had and don't have. But that's how we have to think about those whom we serve. What are those intersections of make them who they are? And how can we fine tune what we do to tailor and improve their experience as a member so that they can have that optimal health outcome? So care delivery and experience is one way, again, centering our member experience, focusing on what is needed individually, not only as populations, but individuals, what do they need and how can we meet those needs? Even if I take one domain of that, and that is addressing health-related social needs, or more commonly, people may refer to it as social determinants of health or social drivers, that is critically important. Again, going outside of the walls of the clinic, going outside of the walls of the hospital. I also think about what we can do internally, our internal operations, building capacity so that our associates who are driving our mission and vision forward can deliver on advancing health equity. And part of that is education and training. Part of that is ensuring that we have the infrastructure to allow us to be successful. I'm sure this will come across later in the discussion. It's come across in your sessions and other parts of the summit, Mary. But being able to, number one, collect effective data, to be able to use that data, be transparent about it, and share it when necessary. But to do that, Mary and Nicole, we have to also be more trusted, right?
Yes.
And so that's what that first pillar about the member experience and journey, building those trusted relationships, because folks aren't going to share information if they don't trust you. And so we, again, one of our missions is being a lifetime trusted health partner, not just healthcare partner, but lifetime trusted health partner, thinking about whole health. And lastly, the third pillar I'll say is what we're doing around growth. And I think, and I put that intentionally last, because I think if we are doing the first two things well, we will grow, because we are delivering on what our core, what is core to what we do, which is advancing health equity. And frankly, I think that we are positioned well to do that. And so I'll stop there.
Yeah, no, I think that is all just spot on when you think about how you have to come in and start building something. So when you talk about, investing in health equity, we want to make sure that, this does not, that becomes more than just a moment, right? And so we understand that there's a lot of focus and attention on it now, but this is really just a launch pad. We aren't anywhere close to done. So how are you thinking about ways and who we need to partner with and who needs to be at the table for us to keep advancing this investment in health equity? Because there's going to have to be investment. The organizations need to understand they're not done when they've put the two of you, in your roles. And just like we've said to a lot of the drug development companies, you're not done when you've diversified your clinical trial. So what do you think needs to happen to make sure that this becomes more than just a moment? We'll start with you, Nicole.
Yes, certainly. So partnerships, investments, absolutely durable commitment is needed. As we think about what this could look like just from kind of a clinical development perspective. And yes, you mentioned it's not enough to just diversify our trials, but that's where we're starting as really the key part of our business. And one of the things that we came to appreciate very early on is that our infrastructure doesn't serve us. So often the sites we call upon most regularly aren't in the right areas or don't have the right capabilities to reach more diverse patient populations. So the first thing we've really done from an investment perspective is think about how we can shift our infrastructure. And so we've made an investment in what we call the Advancing Inclusive Research Site Alliance, which is essentially a partnership model between our organization and sites and investigators that are highly experienced and trusted. So that trust component definitely comes in research in research centers that are actually located in communities with higher Black and or Hispanic populations. And this is certainly something we've come to deeply appreciate too, as the partnership and the face of care is going to be delivered through these relationships with these sites and with these healthcare professionals. And certainly as industry, we appreciate that we are not always a trusted source. So how do we partner with the right people and organizations to ensure that interface is maintained and the trusted relationship and the fidelity of that is maintained? And so what we've done is we've really launched this site alliance. And we've started small in one disease area in oncology, but to really put these sites and these relationships in place to begin to bring more representation into our clinical research programs. And as I think I mentioned too before, the focus piece has been a really critical part of our strategy. But I think the other element to really say that an organization needs to think about, and it seems quite obvious probably, but as a largely scientifically driven or clinically driven organization, we have to rely not on our expertise that we are used to relying on, but certainly looking out to communities, to patients, to advocates, to healthcare professionals to inform and shape and help us understand how we can co-create solutions together. And so I think from a partnership perspective, really not being afraid to initiate new partnerships. Our alliance model is the first of its kind. It certainly won't be the last, because we have to deepen partnerships where we actually have them, but we have to create new partnerships as well. So we also have a council that we leverage in partnership that includes healthcare professionals and advocates and thought leaders that help also inform and validate our thinking. So I think for an industry organization, the key has been that we don't have the answers. We can be willing, but we have to be willing to learn, and we have to be open to new solutions and new ways of thinking and really non-traditional partnerships. Mm-hmm. And I think that durable commitment comes in the form of a public declaration as well, which we've also done. And I think that really helps hold, large organizations to meet the goals and aspirations that we're talking about today.
Thank you. And so, Darrell, when you think about the types of partnerships and the types of structures that are in place that maybe need to be undone, I mean, some of the panelists and previous panelists have referenced the fact that the healthcare system itself was structured in the 1960s and earlier, which was a very racist time. And so a lot of the structural racism is inherent throughout the entire healthcare system. So there's got to be this balance, right, of deconstructing the old but building the new. And how do you do that, and what kinds of partnerships? Who are your partners in doing this and moving this forward internally and externally?
Yeah, no, I appreciate that reference that you made, and I think it was Paul Batalden. You have to keep me honest, but I think it was Paul Batalden who said every system is perfectly designed to get the results that it gets. And right. So I think, as I think about partnerships, what we have to do in our partnerships and what we are doing is ensuring that we're embedding health equity and advancing health equity in all that we do by design. And so as I think about partnerships, I referenced earlier, number one, building the internal capacity to deliver on equity. And what does that mean? That requires that within our system, we bust any silos that are existing. Because all too often there are elements of different organizations that may be working on similar things, but aren't working together. And so ensuring that we don't have silos is extremely important. Matter of fact, we're bringing leaders across our enterprise together in what we call a health equity advisory roundtable. This is all lines of our business, bringing together to make sure that we are one band, one sound, marching towards health equity. And as I think about it too, the other piece is we try to embed health equity in all we do by design. It's important that we have accountability. That's part of the structure. That's part of the design. And so as I think about accountability, how do we do that? In one part, it's performance review. How do you tie metrics to performance review? Yeah. How do you tie metrics to incentive plans? That's accountability, and that's how we're building upon that structure. But as I think about partnerships, again, I want to really underscore something that is core to all that we do, and that is centering the member, person-centered, human-centered care. And so the more that we in our partnerships elevate the voice of our members, that's how we will advance health equity. And whether that is amplifying member stories, I think about a story. There was a member in Kentucky who sent us in a card. And very briefly, she had been engaging with our group, particularly our community engagement navigator, on different issues. She had been facing some food insecurity, and we were able to help navigate beyond that. But she had faced an emergent crisis where she got a tax bill where she was actually at risk for losing her home. Wow. And we were able to help her navigate that and alleviate that tax bill issue. She kept her home. But the card said, not only thank you, but why would you do that? Why would you as Anthem devote any resource to help me keep my home? Is that part of your business model? But that's core to what we do. That's part of baking it into the design, where it's not abnormal for us to do this for our members. Yeah. And so as I think about partnerships, it's actually members themselves, it's community-based organizations, it's our internal capacity to deliver on health equity by ensuring that, number one, our associates are knowledgeable, that they're dedicated, but they're held accountable, like what I just said there. So that's just a few highlights there.
So when you think about solutions, especially when you want patient-centered care, member-centered care, I'd like to hear from both of you very quickly about the potential for digital solutions. And how are you thinking about that? And what's your perspective on the ability of our digital advances to help us achieve health equity, and certainly your organization? So starting with you, Darrell.
Yeah, so I'll use an example. Many of you probably fresh still on your mind when we first started into the pandemic in early 2020. I was in the clinic, and so I was front and center with a lot of this. But you'll know that many people initially could not get access to their care provider. And we were thrust into a telehealth revolution. And unfortunately, that meant that a lot of people were falling through the cracks, right? Because perhaps they didn't have Wi-Fi or broadband access. Or maybe they had the Wi-Fi and broadband, but they didn't have the device to be able to access their healthcare provider. Or maybe they had the device, but they didn't know how to use it effectively to meaningfully interact with their healthcare provider. Mm-hmm. So there is a desperate need, certainly, for digital solutions. And we, I think, have been really effective in kind of solving for that as we think about, we've been forced to think about our telehealth solutions, right? What I think we continue to need, and I'm just talking about in general, and I'm talking to our vendors who are listening and tuning into your summit, I'm talking to business leaders, is we need to think about those who may be left behind, right? Yeah. So there are many virtual first solutions as we think about primary care or behavioral health, and many leveraging telehealth platforms. Mm-hmm. But what about that member who is visually impaired? Yeah. What about that member or person in the community who does not speak English efficiently? Mm-hmm. How does your technology cater to the needs of that member, of that person, of that consumer? And I think that's one thing, as we think about all of the revolution that's happening in technology to improve care and experience, we have to think about first, who could be left behind, or how could we exacerbate inequities with the technology that we are pushing forward? You know, certainly there's an AI revolution, artificial intelligence, machine learning, and this is great. But we also have to look through a lens of bias that we introduce with these algorithms with artificial intelligence and machine learning. That is only as good as the person that is making the program and algorithm, and they come into it with their own biases. You know, fortunately, I think about the work that we're doing here at Anthem. We have an Office of Responsible AI to do just that, to want to identify risk for introducing bias and then mitigate that risk. So I think, you know, certainly there is tremendous opportunity that we have. I'm sure there's some VCs that are tuning in to the summit. I'm sure that there are some founders who are doing, but always think about who could be left behind. And I challenge those who are in a position to procure new vendor relationships to ask critical questions. Who's on the board of your organization? Who who is your technology intended for and who could be left behind? I mean, these are just starter questions, right? But these are critical questions as we think about the digital revolution that is occurring and the risk of exacerbating inequities with these solutions.
Yeah, thank you. That is spot on. And Nicole, I know that a lot of these things touch, when you look at the digital aspects, a lot of the things, the new technologies coming out, for example, folks are, as Darrell alluded to, there are innovators and VCs and entrepreneurs who are coming up with all different kinds of ideas. And a lot of that is focused on clinical trials. There's Science 37 does virtual clinical trials that appear to be really helping with diversity and H1. These are folks that were just on the summit yesterday. So, but H1 that has this platform where they are tracking physicians and identifying diverse physicians globally. But tell us about how you see digital solutions and how they can help, but also your watch outs for it.
Yeah, I mean, I fully agree with Darrell. I think he covered a lot of the really key points. I mean, obviously, there's immense opportunity here with tools that can help alleviate patient burden with, as you're mentioning, Mary, kind of virtual visits. And I think we've already started to leverage that. I think in the research space, certainly more broadly, it could be used in healthcare. Some of the key points we've been thinking about internally with digital solutions are around exactly what Darrell said, but it's kind of like a quality check. So it's like, you should have these key questions or key considerations in everything you do. It's like a quality check. It has to be included as part of your practice. And we're trying to embed it into the business model itself. It's almost like, I hate to say the word SOP because people hate that, but just really to think about how do you embed this into, you can't get past it. And so then it helps people think through what questions they should ask. So around, what patient populations might be left behind, who might have difficulty, who are you trying to serve, what would happen if. I think the other avenue here is around what data is available to inform your solutions, your tools, and your algorithm development, right? So, AI can't create information. It is subject to the information it is fed. Obviously, there's the interface on the person that helps construct that, but at some level, the data is the data. And the data that goes in is the information that the algorithms can use to understand what the output would be. And I think one of the biggest challenges that we all appreciate is that not just clinical trial data, but most large data cohorts are incredibly homogeneous, and they don't represent the diversity of patients who experience disease. So the first element is how diverse is the data, how representative is the data, what are the implications if it's not, and then how do we mitigate to get more data diversity that informs these tools and solutions, but also while we're building them, knowing that a lot of data sources are flawed, how do we have these checks and balances in place such that we don't create products that really exacerbate or create the next era, essentially, of health inequity? And I think this is really where personalized care and the focus on personalized care becomes so important. And I love this whole person focus. I think that's actually what personalized care is. It's interesting, if you think about the facets of health, right? Because the vast majority of one's health outcome is based on social aspects versus biologic. And so really having that appreciation as we try to think about any healthcare solution is critical. But I think that's going to be an evolution as well, so that there's an appreciation of the facets of health and how we can be mindful of how those affect health outcomes disproportionately. So when we start talking about tools and technologies and new opportunities. And I love that this conversation is happening, Mary, because I mean, you're hosting exactly the right discussions, and this is really where that awareness will continue to grow. And it's wonderful to hear that there's responsible groups that focus on how AI is used. Certainly, we all know these stories. There are numerous stories around bias. So this will happen if we don't prevent it. So we have to define how we're going to do so.
And I do think, the recognition and awareness and, convincing people almost, and I'd like to hear your thoughts, whether you feel like we do still need to convince people, but I know it's something that I find myself explaining constantly about the fact that the bias exists throughout the whole process, throughout the whole ecosystem. And I don't know if enough people really either believe that or just recognize it and see it. So, because how can you really focus 100% on fixing something that you don't even see, you don't even, believe it exists? But, either one of you, your thoughts about that and the fact that it really does exist throughout the whole thing, and how can we get people to understand that?
Yeah, it's such an important question, because the truth of the matter is we all have biases, all of us. In one way or another, we have some bias that can unfortunately influence how we carry out our work and who it could affect. Sadly, unfortunately, as we look at health and healthcare, we've seen so many instances of where, for example, implicit bias. I'm not even talking about racism. And certainly racism has had and well-documented, evidence-based, how it impacts health. But certainly implicit bias, speaking of that, we've seen how it's had impact on maternal health outcomes, behavioral health outcomes, cardiovascular health outcomes. And this is evidence-based. I'm not speaking out the side of my cheek, but this is in the literature. Right. And so I think, part of it, yes, there is a place and importance and a necessity for things like implicit bias mitigation, identification, training, things like that. But that's only part of a solution, right? We have to be very evidence-focused, data-driven, metric also driven, so that people, because there's always going to be some bias. Mm-hmm. But if we are driving toward a mission, if we are driving towards a vision, specific metrics, we can start marching along and better identifying where the bias exists, addressing it when it happens, but also hopefully being more proactive as opposed to reactive.
Yeah, exactly. So as we get close to our close, I want to ask you all, each of you, to tell me, what is your vision of success? This is you, looking ahead on the horizon to see what's coming. What does success in advancing health equity look like to you? And what are the 2 or 3 things that you see that needs to happen or will have happened over the next, 3 years, 5 years, 10 years? What does that look like to you as you are doing this work? And I'll start with you, Nicole, and then Darrell.
I guess I would come back to, also to bring your prior point around, convincing and health equity. And I think part of success will be that is not the need. I think, our company actually conducted a health equity study we interviewed over 2,000 patients from medically disenfranchised groups that were either Black, Hispanic, or LGBTQ+ or low socioeconomic status. And one of the key results was that, largely patients don't feel like they're treated fairly and equally. So I think success would be that data point has shifted and that patients do feel like they're treated fairly and equally in the care system, because the data says that's not the case. But I think that a lot of providers, and this was another data element, don't believe they're treating patients unfairly and unequitably. And I think what we really need to do is take the burden off the patients and help also providers, so that it's not pointing fingers, but certainly the patients can't bear the burden of correcting something like this. And I think a piece of it's data and information, but there's a piece of it that is kind of hearts and minds and experience. That will be a journey, and probably quite a long one. From a success perspective, I would hope that all patients can feel that they can access quality care, and that the medicines that are developed and the healthcare solutions that are developed for them are informed by them, that they're validated in patient populations that are aligned to what they experience. And I would say a key element of that kind of comes back to this whole patient health. We have to be thinking about patients in their totality. We can't parse people into little categories. We have to focus, right? So we have to start somewhere, and I fully appreciate that need. But I think what I would see as success nearest term is for us to really start thinking differently about what we're trying to achieve in preserving health, protecting patients, patients feeling like they can receive care and that they're heard. And I think that's where probably elevating stories and personal information, personal stories can really help people, even if they're not from that background or they don't have the same lived experience. They can at least start to see. So that would be what I think success will look like nearer term.
Excellent. Darrell?
Thanks. And, I think about health equity as an outcome, right? And so I personally am not satisfied until we achieve health equity, when everyone has a fair and just opportunity to be as healthy as possible. That is success. Now, certainly, advancing health equity is also a process, right? So we can celebrate incremental wins on that journey to that outcome. And so success can look like, for example, within our health equity strategy, we are prioritizing a few things that cut across whole person health, but also cut across demographics, whether it be race, ethnicity, geography, disability, and the list goes on. And that's maternal health equity, behavioral health equity, and pharmacoequity. I think we can make meaningful traction and difference in those areas in advancing health equity in totality. But that's part of that incremental change. But know that I won't be satisfied or content until we get to health equity. But as I see over the short term, to get to your question, Mary, I think those are areas in which we can help lead and make a meaningful difference nationally as well. As you're well aware, behavioral health is a national crisis. Maternal health is a national crisis. And even pharmacoequity, ensure that patients, members, consumers have access to evidence-based medication equitably. And that it's affordable and accessible. And so I think we can make meaningful difference in that. And I look forward to being part of that solution.
I like that because you don't hear that one as much, the pharmacoequity. And I like how you put that, and that you followed up to describe what that means, because that's something that Dr. Janet Woodcock referenced in her session about the having not only so they don't feel like their job is done just by approving the therapies, but then it's making sure that people have access to those newest therapies. And we do know that people of color are not being offered the latest therapies. So that's huge. And I know that Anthem, Nicole mentioned the health equity survey that Genentech did. Anthem just released its survey not that long, like a month or two ago, if that.
That's right. We had a survey called What's Driving Our Health, or What's Driving Your Health campaign, where we surveyed Americans, and I know I'm cognizant of time, but it was a survey of Americans to understand how they think about social drivers as being impactful in their health. And there were generational differences, there were race-based differences in understanding, but that began a dialogue. And we were fortunate to partner with noted athlete Allison Felix and really getting the message out there. But also it helps us to become even more hyper-focused on what we do to both identify and address health-related social needs or social drivers of health. But I also, Mary, I want to circle back because you pointed out the pharmacoequity term, and I can't take credit for that term. That is a term coined by one of my friends, Dr. Essien, who is at University of Pittsburgh, has done some great work. I think the term he used was first published recently in JAMA. So I'm just borrowing his term, but certainly it's something that we stand behind.
That is great. I appreciate that. And I do think that doing things like having the surveys, those of us that have done the work around communications and who people trust, and what you find is people trust folks who are most like them. So when you go out and do these surveys and you can share the participation in the survey and what the findings are, that makes a big difference in the trusted messenger bringing those messages to folks and them actually believing it. So, I think that is critical to do that, and we need to keep doing that. We can't stop doing the surveys. So we are out of time. I want to thank you both for participating in the summit and for the great advice that you've shared here today.